All right, we are live.
All right, good morning. This is a joint committee meeting between House Human Services and Senate Health and Welfare. It is April 21st. Hard to believe we're moving along that fast. I'm Senator Ginny Lyons, Chair of Health and Welfare in the Senate, and I will ask Representative Pugh to introduce herself.
Thank you, Senator Lyons, and thank you for inviting House Human Services for a joint meeting around CIS. I'm Representative Ann Pugh, Chair of House Human Services.
Terrific. It's just really great to have you all here. The issue of children's integrated services, how it's faring during COVID-19 is important to us. And our committees collectively have been looking at issues related to human services that extend over into health and welfare, healthcare. So I don't want to spend any more time talking, but we have some guests from Department of Children and Families, and I believe Steve and Morgan, sorry, have put together a presentation for us on CIS. And then after that, we'll hear from some other folks who are actually in the trenches as well. So Steve, do you want to begin?
Thank you, Madam Chair. And good morning, Senators, good morning, Representatives. For the record, I am Stephen Rebekah, Deputy Commissioner of the Child Development Division, Department of Children and Families. Thank you very much for the invitation to join this conversation this morning. I'm here together with my colleague, Morgan Cole, who is Director of Children's Integrated Services for the Child Development Division. And we're here to talk to you about some of the successes and also some of the challenges that we're seeing in this response period. We're seeing that the providers in CIS are demonstrating that they are adaptable and resourceful in the current climate, and in many cases have moved over to remote delivery of services following guidance from the Vermont Department of Health and engaging in telemedicine in areas where until recently they provided services in face-to-face interactions. The services by and large are continuing, but we're seeing a drop in the number of referrals during this response period. And frankly, that is hurting a lot of providers' revenue. In response, the Department of Children and Families is working to set up a retainer fund to support providers and help all of us move forward through this period so that we will be ready to continue services when things normalize in Vermont, hopefully soon. I'd like to turn the conversation over to Morgan to provide greater detail.
Thanks, Stephen. And I do have slides that I shared with folks. I don't know how do you all have those in front of you, or do I share my screen, or how does that work?
You can do it either way. We have your PowerPoint on our webpage. If it's easy for you to put it up, feel free to do that. It sometimes makes it easier for everyone. They don't have to go back and forth.
Sure. Yeah. Why don't I put that up on my screen and then people can follow along. It does say the host has disabled participant screen sharing. So I think someone needs to give me permissions to do that.
Nellie will do that. Nellie, are you able to put that sharing up? Nellie, are you there? All right. Morgan, why don't you go ahead?
Sure.
I'm sorry, Madam Chair, just if you make your screen smaller, you can actually put two screens next to each other on your.
Yeah, you can do a A split.
And
Yeah,
then-
good.
Just, yeah.
Okay.
Excuse me,
That's some people's technology, but it is.
Yeah.
excuse me, this
Tony.
is Tony from IT.
Yeah.
Julie Tucker is also listed as a co-host. She should be able to grant screen sharing.
All right, Julie, are you there?
I am, yes, I'm working on it.
Okay, well, let's just wait a minute.
Okay.
And Morgan, as we're going through your slides, do you want to be interrupted with questions, or would you prefer until you complete your presentation?
It's I can keep it pretty short. It's only a few slides. So it would be helpful if we were able to hold questions for the end. And I also understand that's not always feasible. So.
You know, if it's a question of understanding exactly what's
Sure.
there, we'll allow for that. But if it gets into a broader question, we'll
Great.
try and hold ourselves off.
Sounds good. Thank you.
All right.
Senator Lyons, perhaps you should go ahead. I'm waiting for Nellie because she's the host. She needs to do something.
Okay. All
Okay.
right. We'll
can
do that.
jump in.
Morgan, why don't you go right ahead? And we do have your slides. I hope everyone's able to access those. I
Great.
think they should be on both of our web pages. I've got our Senate web page up.
Okay.
All
So
right.
For the record, I'm Morgan Cole, Director of Children's Integrated Services with the Child Development Division. All right. So I know that folks have had their minds all over the place and working on a lot of different stuff right now. So just as a quick recap, Children's Integrated Services provides services for families prenatally through age 5. We have 4 core service areas, including early intervention, specialized childcare, home visiting, and mental health services. And these are delivered primarily through what we refer to as the bundled contracts with a fiscal agent in each region of the state who then delivers or subcontracts for the delivery of services. Yay, now folks can see this on the screen as well, it looks like.
Terrific.
All right, so next, so that slide there gives a quick reminder of our services. And we have a budget of about $9.2 million for those bundled contracts. Those are reimbursed using a monthly case rate with contract totals for each region. And as people are aware, we've been going through a significant payment reform process over the past year, which was due to be implemented in part in July. Next slide. So this is just a real quick recap of what Stephen said and what I'll be getting into some detail about. We are seeing impacts both in service delivery as well as fiscal impacts, which are closely related. We have had a shift to remote service delivery. There are some barriers to engagement for families in that way, but it's overall working fairly well. Providers are reporting an initial drop in caseload, as well as an increase in the complexity of cases that they're seeing. We are also seeing a significant drop in referrals and trying to plan ahead and anticipate for a potential later surge in population need related to COVID-19 as the state begins to reopen and folks start to re-engage with services and referrals start to come through. Those service impacts all translate to fiscal impacts as well. So we're seeing a revenue loss in the immediate term for providers due to those decreased caseloads and referrals. And we are also thinking ahead about possible impacts in FY21 as those impacts continue to play out and those referrals continue to impact the billable caseload that we have. And I want to share a little bit about our state response. We've really been working with the field to support use of remote service delivery, working with our federal partners as well as other state partners to allow some increased flexibility in how to meet federal and state requirements around our service delivery. We are standing up a provider retainer fund for that near-term fiscal relief. And we have instituted some new communication mechanisms and regular sharing of best practices to try and support the field during this time. A big piece on our state response to-do list right now is those July 1st contracts and making a decision and evaluating our options of how to move forward around that. Next slide. So that was the high level, getting into just a little bit more detail in terms of how COVID-19 is impacting service delivery and families engaged with CIS, or as the case may be, not engaged with CIS when perhaps they should be. We are seeing increased family needs among those that are being served by CIS currently. So they are struggling with all of the impacts of COVID-19, many of which CIS is the primary mechanism for addressing in terms of addressing developmental challenges in the face of childcare closures, dealing with those economic impacts and stressors that are resulting for families, concerns around child safety in the current context, and just general increased anxiety, in some cases trauma, all of that. We are bracing for those same issues to likely increase as the state begins to reopen and families that are not currently accessing CIS services for one reason or another will eventually be doing so. We have shifted to remote service delivery, so we have aligned our work on that very closely with DIVA's work. So that has allowed services, both those delivered within the CIS bundle, as well as fee-for-service early intervention services. Those are often those individual therapies and evaluations, occupational therapy, speech, physical therapy, for young children to be delivered via remote means, whether that's telehealth with audio and visual or telephonic means. We have been paying attention to service continuity issues. So the allowance for increased use of remote service delivery has certainly helped mitigate some of the service interruptions and disruptions that we would otherwise be seeing. However, we are hearing from the field that there are regions that report families either struggling to access those services because they don't have reliable internet service at their house, they don't have great cell reception or minutes on their cell phone, that sort of thing. Or they're choosing not to engage with those services because they either don't feel that it is as productive and meaningful, or because they are just feeling overwhelmed with everything going on right now and have asked to put a pause on service delivery. So that is what's translating to the more immediate reductions in caseload. We are continuing to provide services from our specialized childcare coordinators. That's particularly relevant right now because even though the volume of children and families that they support has decreased significantly with the closure of childcare programs, the children of essential workers, those children who have specialized needs, some of them have had to shift from their regular childcare program, if those have been closed, to another program that is serving essential workers. And so the work of the specialized childcare coordinators to ensure that happens in as streamlined a way as possible, and that both the families and the childcare programs now serving these kids have adequate supports. That work continues and is really important, and is definitely going to ramp up as things begin to reopen and the childcare system reopens more fully. And lastly, specialized childcare transportation is continuing to be provided where there is a need. Next slide. So in terms of our state response to address some of those family and services impacts, we have issued guidance to halt nearly all in-person service delivery. That was in accordance with VDH guidelines. We have, as addressed, increased the ability to provide services remotely, increased flexibility for meeting federal and state requirements around service delivery. We have been in close communication with our federal partners at the Office of Special Education Programs. The field has expressed some concerns and anxiety, understandably, about to what degree and how strictly will they be held to some of the federal requirements around things like timeliness of service delivery. That's not something that we have guidance yet from the federal partners on. However, we will communicate that as we have it, and have been encouraging providers to make sure that they are documenting their work and those extenuating circumstances thoroughly, so that at such a time that we do have better guidance, that we are able to look back and make sure that those mitigating factors are incorporated as much as possible in terms of our compliance activities, essentially. We've been working with BBF around, identifying and ensuring families have resources shared around information and support for them. And as mentioned, we've instituted several new communication mechanisms to support good communication with the field. Next slide. So getting into the fiscal impacts, I've really broken that up into the immediate impacts that we're seeing, which are anticipated to carry on for a while, as well as those that we are trying to be proactive and planning ahead for, because this, as we all know, is not going to, suddenly turn off with the flip of a switch. So those immediate impacts that we are seeing, there has been an initial drop in the billable caseloads that providers are serving. That ranges from what we've been told anywhere from 5% up to 25%. That is exacerbated, I would say, or there's a contributing factor that there's also some staffing challenges that are starting to come up that impact service delivery. All of that in terms of service delivery and billable caseloads really impacts reimbursement directly, because they have a contract total, but within that they are reimbursed using a monthly case rate for every client served each month. So regardless of what their contract total is for, they're not able to draw that all down if they're not able to provide the services needed to do so. So that is translating to a subsequent loss in revenue that is consistent with whatever their billable caseload drop is. The other factor that we're seeing that is looking out a little ways is that drop in referrals. That is up at as high as 75% in some regions, which is huge, and that is going to be a significant impact pretty soon, because as clients naturally move off of the caseload and exit services and they are not replaced with new referrals, that means that those caseloads are going to drop pretty drastically if that 75% holds for very long. And even once things reopen, so our regular referral sources are things like childcare programs and pediatricians' offices, and those sorts of places that are just not seeing the volume of children and families that they normally would. It's going to take a while for those referral systems to ramp back up. This is also impacted by regions' inability to provide the level of outreach efforts that they normally would to reach more families. So things like having someone attend local play groups and talking to families about services, that sort of thing. So that is going to hit pretty soon and have an impact for a while as those referrals ramp back up. We are also anticipating, as I touched on, a potential surge in case complexity and caseload once things really do open back up and referrals are coming back in. I suspect those will come in with a bang, and that's what we're hearing from the field in terms of what they're anticipating as well. That is going to be due to some of the pent-up demand of children that had been identified as needing services but chosen not to engage, or that normally would have been identified and haven't yet, just through the normal course of business. That will also include, most likely, families that have been directly impacted by COVID-19 in a way that necessitates the need for CIS service delivery. So those are some of those family stressors that I touched on earlier. Having parents out of work, having children no longer in childcare, having all of those factors and stressors that are happening right now due to COVID. CIS is the primary mechanism for developing for addressing many of those impacts. So that's something that we're bracing ourselves for, both in terms of the number of families needing services and the complexity of those services and the time it takes to meet their needs. So that really brings us to these July 1st transitions. And this is something that our partners in the field are having a lot of understandable anxiety about, and we are doing a lot of work to try and consider what the available options are. As people may recall, the intention was to move forward with initial contract changes based on our payment reform process on July 1st. That meant implementing a statewide case rate rather than having the significant span of different rates that's currently paid for the same services in different regions right now, bringing us to one standard case rate as indicated by the cost study that was performed, as well as reallocating contract totals across the state, so that regions' contract totals were reflective of the caseload data that they have reported, rather than historical artifacts, essentially. So that will, if it moves forward as planned, that would result in contract reductions to 4 regions, technically 5. One of them is pretty much remaining level though, and contract increases to 4 regions. So we are hearing significant challenges from the field in terms of their ability to do the administrative work needed in the coming months to get their own subcontracts ready and their own fiscal allocations within their region between different service areas ready, so that they can actually implement those contract reductions in those cases on July 1st. Several of our regions' fiscal agents are really flat out right now with day-to-day COVID response. So taking on this fairly significant task of having a data-informed collaborative process to develop those new subcontracts is really challenging in the time available. Additionally, we are scheduled to end the Specialized Childcare Coordinator supplemental grants, which had been in place to carry on the necessary functions of that role in supporting our childcare system for families with children who have specialized needs, many of which are those in FSD custody. Those grants come to an end on July 1st as well. So the dual impact, or I would say the triple impact of COVID impacts and response needed, paired with the planned July 1st contract changes and the end of the Specialized Child Care Coordination grants, is certainly something that we have a lot of concern around and are doing a lot of thinking about what options are available to try and mitigate that. Next slide. So this is some of the thinking and actions that have been taken around that fiscal impact and response from the state. In the near term, we have received the green light to move forward with standing up a provider retainer fund for those bundled services. That the amount of funding available for that is based on the initial reports that we received that regions were seeing about a 20% caseload reduction, and planning for 3 months worth of funds to award. That would be based on demonstrating the revenue that has been lost, rather than necessarily the revenue that would have been available to pull down, but it will have to be directly linked to past caseloads and revenue that they can show that has been reduced. As I mentioned, that 20% caseload reduction is likely to increase in some regions as those referrals continue to go down. Additionally, want to mention that the early intervention private therapists that are funded outside of those bundled contracts, they are eligible for DVA's general provider retainer fund, which is geared more towards providers that are reimbursed on a fee-for-service basis, because they do not have the same level of flexibility in service delivery via remote means necessarily as some of our bundled contracts like the CIS contracts. So that's why we went with a separate mechanism for providing a retainer fund for CIS bundled contracts. And then lastly, doing a lot of thinking about how to move forward on July 1st. There's been so much uncertainty and things evolving on a daily basis that it has not been possible to make an informed decision yet about what is going to be the best course of action on July 1st to try and mitigate those impacts and find the right balance with our available budget. So we are continuing to have those conversations and collect more input and discussion as we're able. So that is it as a high-level overview. Happy to answer specific questions or provide more detail.
Okay, thank you. I know we're going to have lots of questions. I want to start out, I think, first of all, thank you for the work that you're doing. This is a really complex area and it's not simple. We get that. And as you're looking forward to July 1st, I have a couple of questions and then I want to turn it over to Representative Pugh, and then I see Senator Ingram had her hand up. If you're looking at the statewide caseload changes and you're looking at a decrease in the contract for 5 areas and an increase in 4 others, and you've done an assessment, I would think, on what how many of those specific areas have had a loss during COVID. Have they all had some significant downturn in their reimbursement?
So I believe all regions have experienced a drop in their billable caseloads. However, based on the reports that we've received to date, those do vary somewhat significantly. On the lowest end, there's one region that has seen like a 5% reduction in caseload, whereas others are at that 25%. So there's some significant disparity between regions in how this is playing out. I suspect part of that is related to just population size in terms of, how that translates to percentages.
Okay, well, it would seem, I guess, as you're going forward, July 1st, you're going to see a lot of juggling going on. Yes. I'll leave that one there, but then you also have talked about a 20% caseload decrease, but you've also talked about an increase in the complexity because of the stressors that are there. And so if you're talking about reducing the reimbursement, whether it is a bundle payment or fee for service, does it make sense to calculate how to keep those things whole for a little while, at least until some of the hurdles of greater complexity? I mean, some of the stressors are reduced. I'm trying to sort that part out.
Yeah, it's a challenging balancing act right now. I think it's exacerbated by the fact that as our cost study that was performed this past year confirmed, there is a difference between the case rate that our current budget allows us to pay and what we know is the cost of delivering services in normal times. So that's $633 in normal times. I suspect that could arguably be higher given the increased complexity of cases that we're seeing. You could also argue, though, that it is lower because right now there's not the need for travel time, for example. So I'm not going to speculate on what the COVID cost of service delivery is, but we do know that at a minimum, the case rate that we have intended to move forward with on July 1st of $501 is obviously below what the cost study indicated. And so, operating in that reality is challenging to figure out how to best meet the needs of the communities and families right now. The other trade-off is that the contract changes planned for July 1st, while we could consider and are opting to extend current contracts and delay any changes to keep regions that were due to get reductions whole, that would mean that the regions that have been anticipating increases and that were originally going to receive those on January 1st, we delayed that to provide more transition time to July 1st. So those regions will have no longer have those additional funds that they were anticipating coming to them. The last factor around, another factor around the possible extension of contracts is that we do have a requirement currently from the Centers for Medicaid and Medicare Services that we make those updates to our rate methodology by January 1st of 2021. So if we extend current contracts as is with the existing rates where there's so much disparity across regions, that is getting us pretty close down to the wire with that federal requirement. Although, I mean, they could potentially have flexibility on that, but we have not been told that that is an option.
I think I'll hold my questions. I have one more. How about the use of some of the $1.25 billion? Are you putting that into your planning process?
In terms of funding available to AHS for COVID response more broadly?
Yes. Well, in the case of CIS, I think there might be some uses for that monies to support either the workers, telemed, or some other creative solutions. Are you looking at that grant for CIS?
So far, discussions have been in terms of possible fiscal relief have been limited to the current fiscal year and the current contracts. So that would be a question, I think, for Sarah Clark or others in our finance folks.
Okay, we'll follow up on that, I guess, outside of committee, but thank you. Representative Pugh, turn it over to you for a bit. And I should say, Morgan, thank you. This is extremely helpful. Thank you very much.
Thank you for taking the time. I'm really happy to have the opportunity to share with you what's going on.
Good.
Morgan, I echo Senator Lyons' appreciation, both for the work that you and the providers are doing, but also the presentation and the way this was laid out. I would prefer actually Senator Lyons to ask if there are members of House Human Services who have any questions. And if you do, if you could raise your hand on the iPad as a, use the hand raising.
Okay, if that's the case, Senator Ingram had her hand up, so we'll go to her after you have finished. Go ahead.
We actually have Representative Brumstead and Representative Wood who have questions.
All right.
I want to apologize in advance. I have a Bernese Mountain Dog in a cone of shame right outside my office door, so I might mute myself for a moment.
That's okay. We've had lots of things going on in our committee meetings. Okay, so we have Senator Ingram and then Representative Brumstead and Representative Wood in that order.
Thank you. Yeah, and thank you, Morgan. Nice to see you. So I wondered if you could say a little bit more about how your referrals usually work. Do you get, is that from like people's primary care providers even before they've given birth, and then I'm thinking maybe child care providers, or how does that usually happen?
Yeah, sure. Happy to talk about that. So there's a really no wrong door approach around CIS, and we receive referrals from a number of different referral sources. It depends on kind of what the initiating need is for that family in terms of which route they come in. Many of our referrals are for early intervention services, and those are often identified by a pediatrician or family practice doc that through the normal well child visits or discussions with the family identifies that there may be something going on with that family, that there's a potential need for early intervention services due to a developmental delay or disability or risk thereof. We also receive referrals from child care programs who either for the same reason see things going on with the children that are in their care, or with the families that they're serving. That might be a developmental need, or it might be that there's just something else going on with the family that they think they could benefit from some additional support. We do also receive some referrals prenatally through or at birth. For example, if a infant is born with a positive screen for opioids, that is generally an automatic referral to CIS for services. So there's really a wide range of referral sources. We get a number of self-referrals. Our parent-child centers, often who are the CIS providers or subcontractors, provide referrals. So there's a number of different mechanisms, most of which have been directly impacted by the stay-at-home orders.
So since families can't see these other people, that's why you're not getting them.
Yeah, so there's not eyes on families, and there's not the outreach activities happening that normally would occur. So the referrals have slowed down significantly.
Okay, all righty, thank you.
Sure.
Representative Brumsted. And you're muted. Representative Brumsted, you're muted.
I've been trying to unmute me, but I got it. Okay.
You got it.
I thank you, Morgan, very much. This was helpful. I've been looking at children's integrated services for a while, because in the committee I worked on the budget piece of this. And so I just want to go back a little bit to when you talked about the July 1st contracts.
Sure.
And we know from your consultant that came in and did a review that there was the real costs are $633.90 per member per month. In the bundled rate, and that what the governor's budget projected that we could afford was the $501.66, and the difference there we know is about $2.4 million. And my question is, in the COVID federal dollars that are coming in, is there any chance that we could take advantage of that somehow, increasing those rates? Because as you said, COVID has increased the complexity of the cases because of that pent up demand. And then that takes me to my sort of second question that relates, is around the retainer fund and how that might help us in this transition times. I mean, something that we couldn't anticipate what COVID would be like when we were preparing the budget on the House side. And now that budget that we prepared, that we had hoped to increase that, to put that 2.4 million back into the budget, or not back in, but to increase. Now things have changed, but maybe that change could actually help us. And so I'm curious about what you think about that.
Yeah, so I think there's and I'm not privy to all of the discussions around COVID relief fiscal options and opportunities. So I think that is an area that I will defer to our DCF business office as well as AHS finance to talk about what options may be available. I think I have certainly shared with you all some of the impacts that I anticipate based on that input from the field as of July 1st. And I think the reality is that adequately addressing those is challenging when, within our current budget, where we know there is this difference between what we can pay and what the cost of service delivery is. So I think I would defer to fiscal folks to answer questions about availability of COVID relief funds post-July.
So I guess one thing that might be helpful going forward is for us to think about how to really document the increases in complexity of cases and sort of the increase in difficulty in the CIS program, which we already had before, but now we could have a true bit of a real problem. And so if we could document that a bit, it might help us as we look to our finance folks to look at ways to increase those. So I guess that would be my hope.
Yeah, I think in the discussions to date, as I mentioned, have been mostly focused on the immediate kind of economic fiscal relief in the next couple months. And for that, we have certainly been looking at what kind of documentation is available. On the upside, we have instituted about 6 months ago encounter data collection, which is a much more granular level of data about the service delivery that's happening. That's something that we didn't previously have and we now do. So I think that will provide helpful insight into the level of intensity of service delivery that we're seeing and how that may change over time in response to COVID. I think that one of the challenges with that is just the time lag. By the time we have that data and it's gone through the process of being compiled at the regional level and then sent to us and cleaned and all of that, we're already a month or more past. But I think we can work with that, and that will be helpful. I think another reality that that our partners in the field could probably shed some additional light on, but conveying what their input to me and our team has been, is that there's a bit of a challenge in terms of their ability to provide services to meet their capacity to provide services to meet the true population need in light of the reimbursement that they receive. So it's a little bit of a catch-22 because they're not able to, they often struggle with retaining staff, filling vacancies, attracting the folks that are needed to meet the population need. So what they're able to provide in terms of service intensity is not necessarily reflective of what the actual need is among families. So it's that invisible gap that is much harder to document and demonstrate.
Right. And thank you, Morgan, because I couldn't agree more. This is something that our committee has struggled with over the last couple of years of not paying the right amount to these providers. So we lose the providers, we lose the expertise. And it's so good to hear you say that, yeah, you really do hear that and get that. So thank you.
And I'll just add that we, that's a reality in our current situation, even pre-COVID, in terms of there are certainly regions in our state that are struggling to even pull down their full contract totals available to them because of this issue. And I think that will become even more relevant in the time of COVID-19.
So thank you. Thank you, Representative Brumstead. That was a good line of learning. Just a comment that as you're talking about the increased needs that we're going to see, it seems to me that during COVID, there are increased needs on the part of perhaps parents who now don't have access, and that providing some information might be sufficient. So it's a different way of a different service being provided, but I don't know how that's going. Representative Wood, and then Representative Haas, you're up after Representative Wood. Thank you.
Thank you, Senator Lyons. Morgan, a couple of questions. One, I'm wondering about with the provider retainer funds, are you going to be able to do that within the existing $9.2 million that you have allocated? Presumably, since there's lower utilization, that you'd be able to use that underutilization to make those provider sustainability payments. Is that accurate?
My understanding is that is going to be separate from our existing budget line. And
Okay.
that will be general fund dollars as opposed to being able to use Medicaid GC dollars for that. And that would be a good question to bring Sarah Truckle into the loop on to provide some more detail.
Okay, so will it be the general fund match of your current allocation, or you think that you're going to be looking for additional appropriation for that?
I need to defer to Sarah Truckle on that one.
Okay, and I appreciated the conversation and the questions that we were just listening to. I guess the one thing that I would caution us about is not using one-time relief money to bump up rates that we can't sustain on an ongoing basis. So it's an important thing to remember because we kind of have the potential to set providers up for a big fall, and we just need to, be thinking about that, which I'm sure you are. So thank you.
Go ahead, Sandy.
Thank you. Well, first of all, thank you very much, Morgan, for the report. It's very thorough and it's very helpful. You mentioned that as the rollout is planned, that in the prior world, when the rollout was planned for July 1st, that there were some regions that were going to get more money and some regions that were going to get less money. And since you're sitting now in a room with people who come from all over the state, I would like to know which regions are in which bucket.
Yep. So I'm just going to go down the list. Barry was planned to get a very minor decrease of like a few $100s. Bennington will see an increase of 13%. Brattleboro will see an increase of 22%. Chittenden will see a decrease of 7 to 8%. Hartford Orange will see an increase of 11.7%. Lamoille, an increase of 6.3%. Northeast Kingdom, a decrease of 36.6%. Rutland, a decrease of 19.1%. And Springfield is a decrease of 5.6%. This does not include the loss of the specialized child care coordinator grants. That's an additional loss to many of those regions.
So I just have to go back. You went really fast. Bennington is an increase of how much?
13.8%.
13.8. And the next one on your list was?
Brattleboro at 22.8.
That's a plus?
Yes, an increase.
Thank you very much.
Can I ask, I know that Representative Pugh is up next. Can I ask very briefly, based on what data were the changes made overall?
Sure. So there's two factors. One is that determine the contract totals. One is the case rate that was calculated by looking at what our statewide caseload is, and then what our total available budget is. Pretty basic math in terms of determining what we're able to pay to ensure that a payment can be made for every client served. The other factor is what proportion of the statewide caseload each region holds. So if if a particular region holds 10% of the entire statewide caseload, then their contract would represent 10% of the overall statewide budget. So those two factors are what determine the contract totals for each region. The caseload data was what was reported to us directly from the regions based on about 6 months worth of data. We did commit to the field that we would evaluate that caseload data as we went into new contracts for January 1st, 2021. These contracts coming up on July 1st were always intended to be a short 6-month period to have a more incremental implementation of our payment reform process. So that opportunity would allow us the chance to look back at the caseload data when we have a full year's worth and rebalance things as needed.
Just as a quick follow-up to this, when you're looking at the caseload data, does that include the complexity of the cases overall? No, just the individual case costs a certain amount of money.
Yep, there's no, we did consider in the payment reform process and cost study whether or not something like tiered rates for different service intensity was appropriate. And ultimately, the recommendation of the consultant that we worked with for that was to have one standard case rate, which is meant to be encompassing of the spectrum of different complexity that you see.
And then I think my last follow-up on this one is how are you measuring outcomes for the individual cases so that you can determine whether or not your determinations have been effective?
I'm sorry, in terms
are
of
you
whether
measuring outcomes, case outcomes for each case? Are you getting a report back on how well the individuals are served?
Yeah, so we have a series of performance measures which are used to measure the performance of our services in the field and among different regions. That is based on individual case level data that feeds up into services. So that's things like whether goals were identified by the family on their initial service plan were achieved by the time of exit. Within early intervention, we have a lot of data around outcomes, many of which are related to timely service delivery, as well as achieving developmental status of same age peers, that sort of thing. In terms of looking at individual case data to determine outcomes and differences in terms of intensity of service delivery related to outcomes, that sort of thing, that is not something that currently we have the capacity to do, but we hope to moving forward with the payment reform process. We've entered kind of phase 2 of that payment reform, which is building out our monitoring plan to now that we will have a lot more data available to us with the encounter data, see what we can do with that.
I won't ask my next question. I'm saving it. I think every time you say something, I think it's something else, and that's not fair to Representative Pugh, and then Representative Rosenquist, and then Representative Redmond in that order. So Representative Ann, go ahead.
Thank you. And Morgan, Senator Lyons began the thread of my questions.
I'm sorry.
On some level, I'm not interested in how often someone, what is the type of service, how many times, and how quick it was. I'm more interested in outcomes. And we're talking about payment reform. I'm sorry, I chair the Human Services Committee. I'm interested in people, not money. Or I'm more interested, and I know you need money to do things. But that said, why are we doing this? Why we are you're talking about increasing needs. What kinds of needs? And we have a limited, we clearly have a limited capacity to fund the increasing needs that the COVID-19 pandemic has so strikingly pointed out. So what are we going to do differently? Are we going to, if the pie is the pie going to be the same, or is it going to be a smaller pie? Am I going to get the slice that I need for my family to thrive? Or are you going to divide the slices between all of the families in my community so that everyone gets a little bit, but no one gets sufficient? And those are the kinds of questions. We're talking about payment reform, but in what context? So I don't know. That's what I've been thinking about. How do we respond immediately? And it sounds like you have been doing that in terms of thinking about increasing for the short time some of the rates, with the proviso that people have to realize that this is not forever. And then where do we go from here?
Yeah, I think those are very important questions and the crux of the issue here. And I don't envy you all the task of having to determine what to do with the limited and highly valuable resources that we do have. I will say that we, collect a fair amount of data with CIS that are related to the factors of, is a family better off, which is, ultimately that most important piece, rather than did they get services in time, or how many services were delivered, that sort of thing. I think, in the absence of a CIS data system that, as folks know, has been tried to be built on several occasions, it's a little bit harder to do that, but we do work hard at that. I think another piece to consider here is we rely really on a lot of the, peer validated research from the past 30 years around early childhood and the return on investment there. So all of the studies show that investing in these type of services early on are what, have the greatest return on investment later in life. A challenge for demonstrating that is that by nature of the services, often that accrues years later. So it's not easy to directly attribute it to the service delivery. So in CIS specifically, something that will help with that is, as the state longitudinal data system that is under development in partnership with AOE, that will certainly help, for just as one example, in terms of being able to see what is the difference between children that receive CIS services beginning at 18 months versus those that don't receive them until they're 4 years old, in determining whether or not they require an IEP and special education services when they're in 4th grade. So there's things like that there is a very clearly demonstrated link between in terms of that return on investment. But so often the savings actually and the impacts accrue to other human services and education systems. So I appreciate the challenge there for sure.
Thank you. Representative Rosenquist.
Thank you. Director Cole, maybe I missed it, but when you were going through those numbers of increases or decreases, I didn't hear St. Albans, and maybe I just blinked or something. And
you did not blank. So St. Albans and Addison are both integrating family services regions. So rather than operating under the CIS contracts, they have an IFS contract or grant with DMH. So while they provide the same services, they have an alternate funding mechanism for that.
Thank you.
How does that funding compare with the others?
It's a bit of an apples to oranges comparison because the IFS model is inclusive of a lot more services because it's a wider age span than CIS. However, I will say that they for example, received the Medicaid increases that came through recently, whereas CIS, for example, did not.
Thank you. Representative Redmond.
Thank you. A question, as you were going down the percentage changes in the different regions, I noticed that the Northeast Kingdom and Rutland have sizable decreases.
Yeah.
Northeast Kingdom 36.6%. Can you just kind of elaborate on why those areas have such dramatic drops?
Yep. So there's two factors that play into that. It's what their case rate was prior to payment reform, and what their anticipated case loads were. So we have regions like Northeast Kingdom, whose case rate historically has been hundreds of dollars higher per child or client served than, for example, the lowest paid regions in the state. So bringing them all to the same level, to that $501, results in a significant impact. The other factor is caseload. So there were regions where there was some significant misalignment between the caseloads that their contracts allowed them to be reimbursed for and the number of clients that they actually served. So what we found ourselves in is a situation where regions were serving clients even after they had already pulled down their full contract totals. So there were clients, you know, in need of services and eligible for them that the contracts did not allow for reimbursement of. So those two factors played into making those significant changes in regions.
Do you have any concerns about the ability to serve the community there based on such a dramatic shift?
Yes. And I think I have those concerns across the board in terms of the case rate that we're able to pay and the cost of delivering services. And I think this was a extremely challenging process and decision to determine how to move forward. And what I think we really focused on grounding ourselves in was having this be as transparent, data informed, and equitable a process as possible. Also we did commit, which I haven't mentioned and should, we did commit to providing transitional support grants for that period of July 1st through December to the regions anticipating reductions. So we essentially kept a small portion of the overall $9.2 million budget out of the full pot essentially for the state just for this 1 6-month period in order to provide some additional supports to those regions getting reductions. So those in total come to about $100,000. So it's not massive. But for example, Northeast Kingdom is due to receive a transitional grant of $56,000. So the idea there being that will help cushion the blow and assist with that transition period to give some additional time on top of the 6-month extension that we already put in place from the originally planned date of December to determine how to implement those reductions.
Thank you.
All right, thank you. I think we have one more question from Morgan, and then we'll move on to our next witness. Topper McFawn, I think you are up. You're muted. We can't hear you.
Director Cole, thanks very much for that presentation. It was very helpful. I do have a question though. As we transition to near normal activities, and you're in the planning of service delivery going forward and the payment reform, my question is, are you getting any monetary guidance based on the fact, the impact of COVID-19 on the revenue that's coming into the state? Because you got some pretty big moves here, and I'm just wondering if you're getting any monetary guidance.
Can you tell me a little bit more what you mean by that?
Well, the state, the revenues coming into the state are way down.
Mhm.
And the payment reform and the service delivery with maybe the more complicated cases probably going to cost more money. And what I'm trying to get to is, are you being told that you are going to have enough money to do the kinds of things that you're planning, or are you being told something different?
To date, I have been working with the current budgetary availability and assumptions that I have.
Okay, thank you.
Okay. It sounds like both of our committees are going to be wanting to know a little bit more about the financial outlook, especially with respect to any federal funds that are coming to us, and then the payment reform that's going to happen sooner or later. So, and I think that's Sarah Clark in the agency. So maybe that would be something to follow up with. We did have her with us last week in our committee, but maybe we can have her back at some point. So thank you very much, Morgan and Steve both. We greatly appreciate the work that you're doing as Deputy Commissioner and as Director. And we'll stay connected. But if you're still around, that would be great, because we're going to listen now to some testimony from Chloe Leary from the Winston Prouty Center. And Chloe, are you here? There you are.
Hi,
so
everyone.
do we? I think we have something on our webpage from you as well.
Actually, it's from Morgan, technically.
It's actually from, okay.
Yeah.
Oh, it's that one. Okay, good. All right.
Yeah. Good morning. My name is Chloe Leary. I'm the Executive Director of the Winston Prouty Center. We are the CIS fiscal agent in Brattleboro. We provide a bulk of the services in the region, and we contract with HCRS for mental health, and we work with visiting nurses for strong families home visiting. I am so heartened to hear the level of conversation about children's integrated services in this hearing and the excellent questions. I feel like the awareness is really going to help us get through this all together. I'm going to keep it short because Morgan really conveyed. I can verify that as a partner in the field, this experience and what she described as happening is what we're experiencing in the field. We are challenged by moving from in-person services to virtual services. So in terms of family engagement, it's very hard. And some families have more wherewithal than others. And then staying financially afloat is really important to get through this time. So in a system where we're relying on family contact to pull down funding, we've been very concerned about how to stay afloat, and we're heartened to receive the memo that you all have access to. That was really, last Thursday was a highlight for us in terms of understanding how can we move forward, provide services, bill for what we are able to do, and get through this period. So that was, I think the other thing that is really coming through is the assurance from our partners at AHS that we're going to have to keep talking and thinking creatively about how important it is for this system to stay whole. If the CIS infrastructure crumbles at all or is weakened, it's not, when we get through this, that social services surge that I think many of us are anticipating, we have to be ready for it. And so whatever we can do to keep this system strong right now, we will pay off in the long run. So hearing about the retainer fund and just all I think the willingness to communicate and stay in touch with and hear from the field about what is needed is very heartening. So I think that CIS will be, it's meant ideally as prevention and early intervention so we can get some of that return on investment. We are not going to get there again for a while. And so I think now adequate funding is even more important. And thinking about, Morgan did a great job, I think, of talking about the case rate. And I'm curious if we are able to get everybody to the case rate, rather than thinking of sort of the current budget, would that help us sort of get through this too? So those regions that are anticipating a loss, if we were paying the full case rate that we know it costs, would that help? So I think it's an interesting question, but certainly we're doing everything we can to figure out how to support children and families right now. We're worried about our most vulnerable families, no eyes on, and just how to stay connected. But we certainly know that this support and collaboration and awareness of the importance of children's integrated services is what is really going to help us get through and exist in the new normal, whatever that is. So I greatly appreciate everybody sort of understanding what we're doing, asking great questions, and keeping it on the radar as we all get through this together. I'm happy to answer any questions.
Questions for Chloe? I have one question, Chloe. When you were talking about the case rate issue and trying to bring everybody into at the same level, as you're looking at what the needs are for the kids and the families, how would you? Do you have any suggestions, or have you made suggestions to Morgan and others about how to either tier or put the case rate in place that meets the complexity of the needs that you're seeing?
So yeah, I think a $633 case rate covers a full spectrum of services. And so in a managed care environment, there are some services we deliver that we can bill for that didn't cost that full $633. So if we see a family, once a week, or even, every other week, and do a check-in, that didn't, and we bill for it, could sound like an overpayment. But the family that we saw twice a week for 4 weeks, that clearly costs more than $633, is, that's where the balance is. And so I guess I felt like the consultants did a great job of looking at the data. I think the question, and what other regions will tell you, is how good is their data, because we don't have a data system. So we're doing it by hand. And some regions are, able to, I think we put a lot of effort into our data tracking. And I think that was good. And I understand not everybody has the capacity to do that. So it's the quality of the data, Senator Lyons, I think, and whether or not the case rate actually does cover that full range of services. I think a tiered case payment rate would probably get us back into more of a fee for service model. I think managed care is great for children's integrated services. It's flexible. It lets us meet families where they are and respond accordingly. So that's sort of my sense of how to handle that.
Oh, thank you. That's very helpful. I have another question, but I'm going to ask Representative Redmond. She also has a question. Go ahead.
Thank you. I'm curious, so Brattleboro is going to see a nice increase in terms of funding. And I'm wondering if I guess I'm curious how you feel that will impact things for you. Are you still concerned about the rate differential, or do you feel like that'll give you a nice infusion? That's one question. And then the other question, I'm just curious about the people that do the work for you in the field. Are you struggling with workforce? Are you struggling to get people to go out and do the work? We've heard those stories all over the state. I'm curious what your reality is.
Sure. So yes, in terms of the case rate increase for our region, it is because we've been operating at level funding for so many years. It's sort of it feels like it's a huge help. And we've been operating at a deficit. We have made up So it's sort of a both. It's an increase, but it's also going to backfill some of the ways we've been creative about providing the services. So I do feel very fortunate as a region, and I'm concerned about my colleagues around the state. I think the Northeast Kingdom is a critical area for services to happen. How could they possibly sustain that? So I'd be very interested in these ongoing conversations about how to phase it in or do transition grants, or what can we do? So in terms of services right now, there are not in-person services happening. So we have kept all staff on because we are essentially providing services. They look different. So we were able, I think, to bill most of our March numbers because this kind of hit in the middle of March. So April, these next couple of months, I think will really be an indication of how well we are able to engage with families and what that looks like, and getting feedback from staff about what it feels like if they're feeling successful. I think what we've heard is a mix of, we've heard some really great stories about an early intervention evaluation that happened over Zoom. That was incredible. And so there's really heartening stories, and then there's really, I can't get through to this family, I'm very worried about them. I haven't had anybody say, I think as we start to talk about delivering more in-person services, I think it will be very interesting to see who can stay on that journey with us. I think some staff might not be able to go back to home visiting or not right away. And so we are now starting to think about how do we hold all of that. And we just sent a survey out to staff this week, actually. So I'm happy to let you know what they say, but I'm not really sure what the world's going to look like after this. But hiring is always hard. We aren't able to pay people what they can get in other places. So we lose a lot of people from early intervention to the school district, for instance. So that's always been a challenge. And I think the increase, or looking at the case rate, that is something that would be very helpful, is getting professionals in the field who can actually stay. So does that answer your question?
Yeah, just a quick comment in that what you mentioned about being curious if people are going to want to go back to the in-person. I think that's a legitimate thing for us to think about in terms of workforce. I have a good friend who does this work up in Chittenden County, and she is delighting in being at home and doing it. So I have concerns about that in-person piece going forward. So thank you.
Yeah, and I would say this is fundamentally, I don't know what you all are learning about yourselves in this environment, but I'm learning that there's something that happens in in-person meetings and services that you cannot replicate. And so I would strongly advocate for us to keep moving back to home visiting that is in person. This is not a remote job. That doesn't mean some things can't be done remotely, but it is critically important to have that relationship. That's why I think we are losing engagement, frankly, with families. And again, the families we're most worried about is because you can't just kind of show up and say, oh, hey, here I am. And it's going to.
I agree. Thank
you.
Interesting. Thank you. Any other questions for Chloe? I guess I did have a question. One of the things that you have been talking about, and Morgan Cole talked about a little bit, is how do we measure outcomes, and that you have paperwork, you don't have a digital system for doing that. And I guess this is just a thought question, really, but I think it goes to Morgan and to Steve, Rebekah, but Chloe, you can help too. If we had one-time money, could we put any kind of a system in place that would then sustain itself in some way? I mean, if we had, I know we have some IT money this year or last year that we put into the parent-child centers, and we've also put some IT money into the childcare system. If we had some one-time, I know there's IT money in some of the federal dollars coming to us. We also have that great big chunk that we keep talking about. Is there any sense to one-time investment in IT update of outcomes measurement? I'm throwing that out there to Morgan and Steve and Chloe all at once.
This is Morgan. I can take an initial stab at that. I think there's There's a lot of options that would be very much worth exploring around that. The current vision ultimately is that we would have a child development division integrated data system that would be inclusive of those BFIS childcare functions and the CIS case management functions needed. My understanding of our current status is that the funding is available to move forward on the BFIS childcare side of things, and not available due to not receiving the preschool development grant for the CIS functions currently. I think if we were able to move forward with that vision, that would be incredible. And I think there's also other avenues that could be explored as well.
Do you have any idea of what the total expenditure would have to be to link up all 9?
I don't, I apologize. I think
a lot.
There's been so much work done on trying to build and in fact building, and then just not being able to roll out or complete a CIS data system over the years, that there's been a lot of really good work and thought and development put into it. So I think Mike Nagel would be a resource who could address that better than me.
Wait, who is that?
Mike Nagel with ADS. He's been very closely involved in the CDD and CIS data system work.
Okay. Thank you.
From the field, I would absolutely put a plug in for that. I've been in this is I'll be 13 years, and I've been through like 2 or 3 data system tries all the way back to VFAX. And from a service delivery point of view, it would help us provide better services and save a lot of time. We spend a lot of time tracking data, and that's time that could be used differently. So if there is a way to invest in the IT, I think it would actually make a big difference.
There's also stopgap measures that, you know, I might get in trouble for saying this, but there's a lot of opportunities that are worth exploring. There's regions currently who have data systems that they've built themselves that, you know, yeah, there's a lot of area to explore around this topic.
Ginny, I also wonder if our Government Accountability Committee, that's a joint committee along with Susan Zeller, might be able to help us think about whether or not any of that funding could work and look at it across state government, because it's a fantastic idea that we really should be thinking those are excellent uses of one-time funds that we are desperate for.
Yes, please do that. Please take that to the Government Accountability Committee. I think that's great. Our committee did have some testimony last week from Maria Royal, which we found extremely helpful on what is coming to us on IT. And it might be helpful to hear from her, and then the Department of Public Service also. I know that Senator Cummings' committee in finance has been looking at this, but when you link the human service needs with what is possible and what we have available, it does suggest that we can improve outcomes for people going forward. So I think the more of us that put our finger on that pulse, the better off we are.
Great.
So good, great idea.
Thanks. Your idea.
Oh, well, okay. Any other questions for Chloe or Morgan or
I have my hand
Steve?
up.
I'm sorry, Representative Haas, I see it. Yep, I got you.
So I'm probably just repeating what you both said, but I don't think we can say it too many times. With respect to the federal money, I guess I'm going to say this to the Deputy Commissioner. Can you really push your analysts and lawyers to find the loophole that would allow us to get some of this money for the IT, particularly to meet what we expect are going to be unusual needs? I mean, there's got to be a way to wiggle this so that we can squeeze a little bit of one-time money out. If Vermont was a business, we would have had a new platform 3 times in the last 40 years, and we haven't. And I'm now in my 16th year, and I don't think I go to a single meeting where the answer to at least one question isn't, we can't do that with our system. We have a legacy system. I am tired of that. And what I hear is that we are spending money on people with pencils when they could be giving service to Vermonters.
Oh, we like that speech. Thank you. We're all for it. I don't see anyone not smiling.
And thank you for that encouragement. We certainly have active conversations regularly along those lines.
Thank you. Thank you, Deputy Commissioner Rebekah. That's actually reassuring. And, you know, if we need to, we're going to need the input from our Ledge Council and other folks, but if we need to, we certainly can address this legislatively. And I know that the Joint Fiscal Committee that Senator Cummings and Senator Westman are on, are also looking at the 1.25 billion and are also looking at the other grants that are coming in that include IT. We may not have to find a loophole, Representative Haas. It might actually be something that we take advantage of that's there. So we'll keep our fingers crossed, because I think it does solve a lot of problems. I think you're right on that. Okay, any other questions for our witnesses, our guests? Oh, this is wonderful. And, you know, in the true history of the Senate Health and Welfare Committee, we are finishing early. We'll give you an extra 3 or 4 minutes. Representative Pugh, do you want to have a last word?
No, thank you. This has been fabulous.
All right. It's great. It's great working with all of you, the Human Services Committee. It's we'll have to do it again. It's nice to see you all.
It is nice to see you all.
Yeah.
Thank you for having us here.
All right. Well, our committee meeting is complete, and we will adjourn ourselves to another day. Health and Welfare will meet tomorrow morning at 9:30. We have a joint meeting with House Healthcare, and I'll be communicating with Representative Pugh about some maybe possible future joint meetings so we can keep the work going. Thank you all. Take care.
Thank you.
Ending live stream.